Now I invite Dr. Rajiv Raman. He will be the other side of it. Injections, both anti-VEGF and steroids.
Thank you. It's been pleasure being part of this instruction course for last couple of years, and I'll be next few minutes talking about the role of anti-VEGFs and steroid in proliferative disease and diabetic macular edema. So let's start with diabetic macular edema. There are some guiding principles of treating center involving diabetic macular edema. So you divide it, as Dr. Ajay rightly said, as a center involving and center not involving. Glycemic control, control of BP, lipids, anemia definitely are very crucial to get optimal result. Anti-VEGFs are the first line treatment for center involving diabetic macular edema. You can switch anti-VEGFs, you can switch to laser, you can switch to steroids if you feel that on follow-up it is poorly responding. OCT and vision are the key tests to determine the choice of your initial treatment, and even the follow-up. You want to do these two tests on a regular basis. And in case there is a vitreomacular traction, and in select cases where it is a non-responding DME despite all your efforts, vitrectomy still has a role. So basically, if it is center involving, non-center involving, you look into whether it's a responder. Again, there is no magic number of 3, but you, after a couple of injection, even first injection, you don't see anything, no response, you can still switch. If it is poor responder, you may probably switch to another anti-VEGF or a steroid. So it's not only this. If it is a non-center involving, as Dr. Ajay told, laser has a role. Sometimes it can be a center involving and later converts to a non-center involving. Again, laser has got a role in these cases. However, there are many patient-related factors that also play a role. Patients who had a history of cerebrovascular event in last 3 months, you want to avoid anti-VEGFs, you can consider steroid or laser. As we had discussed, in pregnancy, early pregnancy, you can think of laser and steroid. Late pregnancy, you want to wait for a spontaneous recovery. If you have a patient who has poor compliance, you can consider steroids or laser. And if a person has chronic kidney disease, you start still on anti-VEGF therapy. On follow-up, if you see the renal parameters are worsening, you want to withhold the anti-VEGF for 1 or 2 months and then see how the renal condition is. There are certain eye-related factors which also play a role in decision-making in DME. It's a vitrectomized eye. We have shown in a multicentric study that initially there is no need to be in urgency to treat these edema. Majority of time it can still go away by themselves. If it is in the late post-operative period, steroids may be preferable. It's not like anti-VEGF will not work. You will need more anti-VEGF injection because the vitreous sump is not there. In proliferative diabetic retinopathy with DME, anti-VEGFs become first choice. Definitely needs to be, PRP has to be added, or you can do a little deferred PRP after some time. In pseudophakic eyes, you need to differentiate between pseudophakic and diabetic macular edema, and you can consider steroids in some cases where they have reached a plateau and there is a persistent intraretinal fluid or the vision is not improving. You can think of using steroids. There are certain disease-related factors. If you have a plaque of hard exudate, definitely need to control dyslipidemia. Intravitreal steroids have shown that it works a little better. Again, anti-VEGF, it's not like they won't get rid of exudates, but you'll need more injections. And definitely you need to have adjuvant lipid-lowering agents. We have some evidence that if it is poor vision, thicker retina, probably the newer anti-VEGFs may be much better. And if there is vitreoretinal surface abnormalities, whatever anti-VEGF you use, the response may not be as good as compared to those who don't have that. You may consider intravitreal steroids if there is some visible traction. And if there is definitely a VMT, vitrectomy is the only answer. We do have newer agents for treating diabetic macular edema. Efficacy-wise, they also are similar to all others. They reduce the central subfield thickness, improve vision, They are known to cause early resolution of edema. We have less non-responders. The more importantly, people talk about durability. You may have longer interval of injection-free period with minimum recurrences. Yes, the claim is that there will be less monitoring visit and less injection visit. Time will tell us really it holds true or not. Coming to proliferative diabetic retinopathy, I think Ajay has told very beautifully that DRS study has shown us it reduces the risk of severe vision loss PRP by nearly 50%. It's not only DRS, they followed them up even after 10 years, nearly 20 years follow-up, the same patients. Again, it showed that 42% had retained vision of 20/20. And we were keen to look at that what happens to our Indian population. So we studied patients who have PDR, who underwent laser, 10-year follow-up, more than 900 eyes across the country. And we also found the similar result. Only 1/3 of them need vitrectomy. That means still laser is the mainstay as far as treatment of PDR is concerned. What is the need for changing the treatment at this stage? People think of using anti-VEGF alone. One reason could be they think probably there is a better anatomical outcome. Field loss may be less adverse effect, less progression, maybe or may not more economical. Let's see what anti-VEGF treatment have been, whether it has been successful in achieving this. So Protocol S and Clarity trials were two good trials which looked into use of anti-VEGF in proliferative diabetic retinopathy. So as far as new vessels, it is nearly same. Clarity did show more regression of new vessels. These are all 5 years follow-up study. Functional outcomes were nearly similar, and that was something which was a bit surprising, but what they showed that even the field benefit, that field loss would be less, will not be seen with anti-VEGF because disease still progresses. There will be areas of non-perfusion which will develop, and they will cause a scotoma. Side effects, the vitreous hemorrhage rates were similar. However, with presence of macular edema, definitely anti-VEGF has got an edge. Exactly as I told, the progression of disease still happens. There is ischemia which continues to worsen in both, and definitely cost-wise, we are aware anti-VEGF may not be that cost-effective. Probably anti-VEGF may not replace the pan-retinal photocoagulation. However, it can be used, and biggest concern is the loss to follow-up. Only 60% of the Protocol S patients came for follow-up, and they tried analyzing the patients who were lost to follow-up, and what they found, these patients had poorer vision, they had more TRD, they had more rubiosis, again emphasizing the fact that if you are thinking of treating a patient with anti-VEGF alone, I have a couple of patients whom I am treating, you need to be sure that they have a very good compliance. So to summarize, diabetic macular edema, anti-VEGF still is the first line drug for treating them. The steroids are effective in a select group of patients, and the newer pharmacotherapy is emerging, which is mainly looking at increasing the durability. As far as PDR is concerned, PRP still is the mainstay of treatment. The patient selection is crucial if you are considering using anti-VEGF as a monotherapy, and there is definitive role of intravitreal. I have not touched on that. There is a role of using intravitreal anti-VEGF before diabetic vitrectomies. Thank you very much. I'd like to invite all of you to the retina meeting, APOTS meeting.
Thank you. Thank you, Rajiv. I want only one question. That is, we see a lot of diffuse diabetic macular edemas which don't respond to all the medication, injections, laser, everything you told. What is your suggestion for this big group? Because it's very big. I see it's a clinically challenging situation. How do you tackle this?
Yeah, these are nearly about, if you look at those non-responders in DME, it's about 30 to 40%, which are sizable amount. You don't want to stop giving anti-VEGF, but definitely these are the ones you need to look at systemic factors. Definitely you'll find that there are a lot of derangements which are there. You need to control that. It's good idea if you label them as poor responders. I usually do an angiogram also on them because we routinely follow up only with OCT. when you are looking at that it is just a moderate NPDR with DME, you don't repeat, but when you label them that it's not responding, good idea to do an angiogram.
Yeah, it's simultaneous anti-VEGF for oblique steroid therapy and systemic stringent control. I would say stringent control. You need to be on the patient to get it controlled.
The
That's
other
very,
thing
very
which is
essential.
very common now, because of many of these newer anti-diabetic agents, you have something called as the early worsening of diabetic retinopathy. Their HbA1cs would be, they become many times non-diabetic, and retinopathy will increase. Their diabetic macular edema will be very bad.
Yeah,
Because
especially.
that is also known entity, so you need to be careful. If
And
suddenly
yeah.
he's he's reasonably well, and I see that retinopathy has increased, I check his thing, it may be a very tight control, I think. But there's nothing to worry about that.
You want to say something?
Just the semaglutide is one of that, where
Yeah,
they say
tablets,
one of
yeah.
the reason is that it suddenly brings down the sugar, so.
Correct.
Yeah, thank you, Rajiv, very
It's
much.
also the
And-
change from oral hypoglycemic to insulin. The moment it changes, retinopathy will worsen in type 2.
Those cases, will you not plan a anti-VEGF for some injection therapy and then tell the diabetologist that you now switch?
Many a times they come to us after they visit a diabetologist, and we do see them.
I think close association is
Yeah.
very much required.